So, hi everyone, welcome to our ACRSS Health Talk for the month of May. My name is V. I am the Vietnamese Cancer Patient Navigator with the Asian Cancer Resource and Support Services. Next slide, please. Before we get started, I would like to introduce our Asian Cancer Resource and Support Services program. For those who are not familiar, we are the first Asian Cancer Resource Center in Oregon and aims to address the full cancer continuum from prevention, screening, treatment to survivorship support. And our goal is to increase the culturally and linguistically appropriate cancer resources, educational materials, and also support available to the Asian communities. So you can see on the screen, we have our website and language-specific phone lines that you can reach us. We also have the QR code to make the access a lot easier too. Next slide. So here are a few housekeeping items to keep in mind. Please mute your microphone if you are not speaking. If you have a question, please type that in our chat box and we will gather all of those and answer them at the end via our Q&A. Today's presentation will also be recorded for training purposes. So if you're uncomfortable, you can turn off your camera, and today's PowerPoint will also be able to send to all our attendees based on request. Next slide, please. So with that said, we will now get started. Today's presentation is about personal health management for newly diagnosed cancer patients and family members. Next slide, please. And I will now introduce our first speaker, Tuyen Tran. Tuyen has worked with nonprofit health organizations focusing on cancer for over 15 years. She works closely with diverse community groups to raise awareness through community cancer screening and educational events. She also manages patient education material development to create branded, professionally designed, and health literate materials for patient use. Outside of her work, she enjoys volunteering, traveling, and spending time with her 2- and 6-year-olds and also her loved ones. Please help me welcome Tuyen.
Thank you, V, and thank you, everyone. Thank you for having us today. And I would like to just quickly give a brief overview about Providence Cancer Institute before I introduce our two speakers today. So next slide, please. Thank you. And Providence Cancer Institute has, Providence has about 51 hospitals in 7 states. And you can see from on the screen with the map, we have 7 states with our Providence hospitals, including Alaska. And Providence Cancer Institute is transforming cancer care in Oregon. And I just want to quickly share with you about the data on the screen with survival outcomes for our patients are over the national average. For example, with breast is 99% compared with 91%. And lung cancer is 45% compared with 25% national rate. And we are global leaders in cancer research with over 25 years pioneering immunotherapy research and over 120 research studies. And we have like 25% of our patients are on clinical trials compared with national averages 2 to 4%. And because we approach cancer differently, we have our cancer experts join the daily cancer conferences to discuss on specific cases. Also, we have the whole cancer care team to help and support patients, such as the oncology nurse navigators or the oncology social workers to help patients understand their diagnosis and the treatment, all the next steps and life beyond cancer. And also we have, among our cancer care team, we have the resource specialists help to overcome the barriers to care for patients by helping them, providing them the local resources and services. And speaking of that, it's my pleasure to introduce our first speakers, And next slide, please. Our first speaker is Yue-Yun Do, and she is the colorectal cancer nurse navigator. Yue-Yun has worked with oncology patients for 18 years as an inpatient, outpatient research nurse, and most recently as an oncology nurse navigator. She thinks that is an honor to be part of someone's care at his or her most vulnerable time. She finds it more rewarding to assist patients through their cancer care journey by allaying confusion that may arise from having care in many different clinics. Aside from working with patients, she enjoys traveling, running with her dog, and doing escape rooms. Please join me to welcome Yue-Yun.
Hi. I guess the next slide, please. Hi, I am Yue-Yun, or YY for short, and thank you for the introduction, Tuyen. I've been a colorectal nurse navigator for about 2.5 years right now, and I really enjoy it. And I thank you for welcoming us to share our experience with having a patient go through the experience of being diagnosed with cancer through treatment and towards the end of treatment. So this is a nurse navigator experience and or perspective. And I will refer, as I am a colorectal nurse navigator, I will refer to colorectal cancer cases for examples as I talk through this. May I have the next slide, please? So what happens when there's a diagnosis of cancer? It is detected from a screening procedure. So in the colorectal cancer world, that is the colonoscopy, which is a scope that enters through the anus, up the rectum, and throughout the colon. And so, you know, people may have symptoms that leads them to requiring a colonoscopy, for instance, rectal bleeding, unexplained weight loss, fatigue. And so really they have these screening tools to figure out if there's something going on in the colon. They could also have these cancers detected by a routine screening procedure. Right now, they're changing the requirements for average risk patients to get screened at age 45 now, before it was 50. So, so now you can see on the pictures above that on the left side, there is a picture of a normal mucosa. This is the view of the colonoscopy. And then in the middle picture, you see a little bit of protrusion, like a little growth there. And that is what is called a polyp. And that is an extension of tissue that grows from the colorectal wall. If that goes undetected, it can then form into a mass, and that mass can be cancerous. So if on the colonoscopy, the gastroenterologist finds a polyp, they'll remove it. If there's a mass, then they'll take a biopsy of it. So basically that means they'll take a piece of tissue from it, they'll send it to the pathology department. The pathologist will review the slides under a microscope to see like what are these cells consisted of? Is it cancerous tissue or is it benign tissue? So this is kind of the beginning journey of one of our, our patients who have cancer diagnosed, is that the gastroenterologist tells them that they have cancer. Cancer is a very big word. It elicits a lot of emotions, understandably. Also, the gastroenterologist tells them about what the next steps are, but often the experience of patients is that once they hear the word cancer, they don't it's very difficult to focus on anything else. And so next slide, please. Can we go to the next slide? Thank you. So it's our job as nurse navigators to help reinforce what those next steps are. So we have to, once there is a cancer diagnosis, we have to do workup. We have to find out what the stage of cancer is. So what do I mean by workup? There is systemic staging, which is like a scan that images the full body where cancer could potentially spread. There's local staging also, which is like a very specific scan with very thin slices that looks directly at the tumor and the nodes, the lymph nodes around it, to determine the staging of the tumor and nodal status. And there's labs that are drawn too. So in a colorectal patient, the CEA is a lab that is part of the workup. These are proteins that can be spilled into the blood from the tumor, and often it can show activity of the tumor. Not all the time though. It's about 60% of the time it can show that, but if it shows it, if it doesn't, it's a part of the workup. It's a part of the full picture of what's going on with the patient. So down below, you see that there is the T stage, which is the tumor stage. That's looking at the tumor to see how far that has penetrated the colorectal wall. There is the nodal stage, which is the lymph nodes, as you see in that arrow, of whether or not on the local staging, if those nodes look larger than normal, usually more than 1 centimeter. And then on the picture on the right, the systemic staging will indicate if there are any abnormal lesions that appear outside of the colon, for instance, in the liver or the lung. Next slide, please. So once we have the staging of the cancer, there have been many clinical trials that have been run to determine what is the best treatment for these types of patients. It's a very kind of specific guideline. It's called the NCCN guideline that tells you what the FDA approved treatments are for every stage of cancer. So for instance, stage 1 patients would generally require only surgery. I mean, not that it's still a very, big invasive procedure. And then stage 2 and 3 may also require chemotherapy and chemoradiation. And stage 4 is most often, or it's systemic therapy. So that could be chemotherapy, it could be immunotherapy, it could be biologic therapy, basically therapy that circulates in the system. So, so in stage 4 patients, we already know that those cancer cells has escaped to outside of the system. So it's not been localized. It's actually outside of the system. And so the reason why we need the systemic therapy is because we need therapy that goes throughout the entire body to attack all the cancer cells. So these stages are actually, they are split into 2 categories. There's curative stages and there's the palliative stage. So curative means that the goal is that we eliminate the cancer completely. Palliative means that we have a goal of controlling the cancer. So all of this is information that we as nurse navigators reinforce with the patient. Next slide, please. The location of the tumor could also let us know kind of what to expect, what the patient is to expect as far as changes in their quality of life. So if there's a tumor located in the colon that is resectable, in other words, can be removed by surgery, usually the process is the surgeon takes out the tumor as well as a margin of tissue around the tumor. And then those two ends of what is cut comes together to form an anastomosis. So essentially they're putting back the colon together. And after the surgical recovery period, there isn't too much change to their life. They can pretty much go back to normal life. With the rectal cancer, though, if that requires removal of the entire rectum, that can drastically change a person's life. And the reason for that is because the rectum is the muscle in the large intestine that is what controls bowel movements. So, so without that, the patient may experience bowel dysfunction, may experience diarrhea, may lose some control of their bowel movements. And so these types of things we educate the patient about as well. Next slide, please. So once the patient has been staged and has embarked their medical journey, they are, they meet a lot of people. So this is a slide of all the people that they will likely meet or have involved in their care. And so, for instance, like a rectal cancer patient who requires chemotherapy and radiation and surgery will have a surgeon, will have a medical oncologist, that's the doctor that prescribes the chemotherapy, a radiation oncologist, which is a doctor that prescribes the radiation. If they require a biopsy from their liver or something, they'll meet an interventional radiologist. If they have a naturopath to help with supportive medications, they'll have that. They might need a geneticist too if they have cancer at a young age. So there's a lot of players that the patient will meet, and each type of physician will have its own clinic and its own set of processes. So it can get very complex very quickly for the patient and very confusing. And especially for someone who hasn't really worked in the medical system, it can be very overwhelming. So as nurse navigators, we help try to navigate or direct the patient to the right thing. So for instance, a rectal cancer patient may wonder if, their side effects from chemoradiation should be directed to the medical oncologist office or the radiation oncologist. So that is a totally perfect, appropriate question for me as the nurse navigator to say, what are your side effects? Okay, so if your side effects are hand-foot syndrome, that sounds more like chemotherapy. Call the triage nurse at the medical oncologist office, So it's a very complex system that they have embarked. And this slide just kind of demonstrates how many people can be involved in the patient's care. Can I, next slide, please? So tumor boards are weekly meetings that occur. Actually, they can be weekly, they can be every other week. It just depends on the hospital. But at our center, we have them every week. And they're valuable sessions where physicians from every type of specialty, so like that long list on the left side of the previous slide, all come to this meeting to discuss patient cases. So, and usually they're, complex cases. where the radiologist will show, like in the picture there you see, they'll show a slide or the scan. Excuse me, I'm so sorry. They'll show a slide to show all of the imaging, and the pathologist will then show the slides from the tumor, and they all discuss together how to best manage the patient's care moving forward. So at our center, we are applying for a rectal cancer accreditation, and we are so the requirement for that accreditation is that we have to discuss the patient before start of therapy as well as after surgery. And that the whole point of that is so that way every type of doctor has had the opportunity to state their opinions, and everybody is, decides the plan moving forward. So this has been a very valuable session for deciding on patient care and plan. And when patients hear that their cases are being discussed, it actually reassures them that, it's not just one doctor or two doctors driving their care. It's that all the doctors are meeting and communicating really well to discuss their care. Next slide, please. So as nurse navigators, we also, upon meeting them, identify barriers to treatment. There's evidence that shows that if the patient doesn't have timely treatment, they don't do as well. You are giving the patient more opportunities for the cancer to grow and be uncontrolled. So we identify these barriers, and you'll see around, like in a circle there, all the different types of barriers that can exist with a patient. So for instance, transportation is a big barrier for a lot of patients who have to come to these radiation appointments daily for 5.5 weeks. They just don't have the transportation for it. So that's where we can, come in and say, okay, you have this type of insurance that allows you free transportation. Let's go ahead and use that, and let's give you that resource. So that's an example. Another example is, a lot of patients actually come in without insurance. And so that's where immediately we have to, talk to the financial coordinator or counselors to have them work directly with the patient to get them insurance right away. So that way we can, so the patient can even go to their appointments and receive treatment. So once we identify the barriers, would you mind clicking? And click again. Once we have identified the barriers, there are resources that we can use to help allay some of the issues the patients are experiencing. And Marietta and Tuyen, they're the experts on these resources. So I will save that all the different kinds of resources Providence offers for Marietta's presentation. Can we move on to the next slide? So a lot of times patients are waiting, they're waiting for their appointments, and it can, their appointment to meet the doctor will be like next week or something, in a week. So they feel in this period of time kind of anxious, helpless. They want to be able to do something. Is there something they can do? Because they feel like they can't really do anything before they see the doctor. Well, there is actually a lot of things they can do. So one thing is to help themselves. They can bring a caregiver to the consult. That is actually extremely recommended and important, because with the anticipation of waiting for the appointment and the anxiety of hearing what the physician has to say and everything can make it a very overwhelming experience for the patient, and it'll be very hard for the patient to digest everything, especially in these incredibly informative consults, everything they say. So if they bring a caregiver, like a friend or a family member or somebody that they trust to the appointment, that would be very helpful to help take notes, to be an additional ear, and to gather information. Now, I understand with COVID, it's been difficult to do this. Usually in our clinics, the first consult allows a in-person, like another person to come in. But if they're, if the policies are such that we can't bring a person in, they will usually allow, a phone and a speaker, like to have a speaker phone availability there. A lot of times patients have a lot of questions, understandably. They can write a list of questions when they're in that overwhelming visit. It's easy to forget what they wanted to ask. So write down a list of questions and review that with the doctor. There is a resource that's very helpful that we give to patients, which is a list of questions that that are good questions to ask every type of doctor. So like, these are some questions that you can ask the medical oncologist or a radiation oncologist or a surgeon, blah, blah, blah. So patients do find that very helpful. If they can, identify a spokesperson. So this is somebody who knows what's going on with the patient and can be the person to update everyone, like everyone in their family and friends, of what's going on. Because patients, when they fill the role of the informant, the person that tells everyone what's going on with them, it's a lot of burden, and it's hard for the patient to have to do that big job as they're going through treatment and not feeling well. So it's very important, or it's very highly recommended, to have a spokesperson for the patient to help relieve some of that burden. It's also extremely helpful for the healthcare providers, because then we have one person to talk to that's kind of the point person to help coordinate care and all that stuff. There has been situations where there have been multiple spokespeople for a patient, which has brought some confusion to things, because each spokesperson then had part of the story and they didn't have the full story. So it caused a lot of confusion. So if we can limit to one person, that would be great. And to have that patient's, or I mean, that spokesperson's contact information added to the chart. For non-English speaking patients, it's our policy at Providence that a medically trained translator come to the meeting. But sometimes patients will ask if they could bring their family members to do the translation. So our thought with that is that it's kind of, there's a lot of complex medical terminology that a layperson may not know how to translate. And so there then becomes a concern of accuracy in the information that's passed on to the patient. So it's better to have a medical translator come. And a lot of times it's best to help clarify the preferred dialect, because, the clinic may not know that Chinese has different dialects. They may request for a Chinese translator, which ends up speaking only Mandarin when the patient prefers Cantonese. So it's important to, in the beginning stages, have that preferred dialect be the chosen one for the translator to use. And if possible, bring an English-speaking caregiver to the visit. And then share cultural preferences. We really want the patient to have the best experience with care. So if there are cultural preferences, then it would be helpful if those were shared with the healthcare team. Next slide, please. Patients can also help themselves before treatment by establishing a good baseline of health. And all these things seem very simple, but they are so incredibly important. Hydration is, or being well hydrated is extremely important. A dehydrated body going through chemotherapy is not going to tolerate side effects for very long and may end up in the hospital. So it's very important to drink plenty of fluids. And this is really the patient's opportunity to have the best health before starting treatment where they are unable to maintain this. So hydration is very important, eating well, especially high protein foods. And the reason for that is because whatever treatment the patient ends up getting, whether it's surgery or chemotherapy, there's going to be some tissue damage. And the best way the tissue can repair itself is with a lot of protein in the diet. Exercise has been directly linked, and physical fitness, I should say, has been directly linked with better tolerance of side effects. So exercise is immensely important. And if the patient is smoking, please encourage them to stop smoking. There's surgeries that have been delayed because patients are smoking. So if they're smoking, please have them stop. We have resources to help with smoking or tobacco cessation. Next slide, please. During treatment, as best the patient can, continue to hydrate, eat well, and exercise as tolerated. It's very helpful for patients to sign up for a patient portal chart access. Our Providence uses My Chart. That's where they can get their lab results, they can get their scan results, they can have access to the doctor's notes. This is also a way for patients to be able to communicate with their physicians and their healthcare team for non-urgent messages. And because of the example that I was talking about and other examples of a rectal cancer patient having many different clinics that they're involved with, it's very important to have a list of phone numbers to call the clinics as needed, and then call the nurse navigators for direction if needed, if there's barriers or other needs. And our job as nurse navigators is to check in with them, from time to time as they're in the midst of their chemotherapy or their chemoradiation, to assess needs. So an example of where we can be helpful is, a patient before starting chemotherapy may have had a great appetite and eating very well and had no problems with weight loss or anything like that. Once they started chemotherapy and developed nausea and vomiting and other things, their appetite has been suppressed, and they're only able to eat a small volume of food. So this is where the dietitian may have not been very helpful in the beginning, but would be very helpful in this situation where the patient is losing a lot of weight, because there isn't anyone better to determine a specialized diet for this type of patient who can only tolerate a small volume of food. So that's why we do these check-ins from time to time. Next slide, please. And after each phase of treatment, the nurse navigators also, and what I mean by phase of treatment is, you know, rectal cancer patient could have a phase of chemoradiation, and then there's a phase of chemotherapy. So in between those phases, sometimes the patients feel kind of lost. They don't, you know, they're not on their continuous plan, and they feel like, okay, what's next? So we, as nurse navigators, we ensure that patients are booked and scheduled for their appointments and their scans. So that way they haven't fallen through the cracks, because these appointments and scans can actually be a little bit confusing because, you know, the people responsible for the next, or the clinic that's responsible for the next phase of treatment may be the ones to order the scans. But then, you know, the clinic that's doing the first phase of treatment may think that they're supposed to order the scan. So anyways, it's a way for nurse navigators to smooth out or have good communication between the two clinics. We often present these patients at the tumor board for a response assessment. And what that means is after they've had a phase of treatment, after the scans are done, we review the scans to see if the patient responded well to treatment, because that can then direct us to what comes next. Should the patient have surgery next, or should the patient have more chemo? And then we help patients understand the next steps, as well as communicate with the cancer care team, as I mentioned before. Next slide. And then at the end of treatment, it can be very abrupt. And and when I say end of treatment, we're talking about patients who have been, you know, curative patients, not palliative patients. Palliative patients continue receiving treatment. But for a curative patient at the end of treatment, they may feel like, oh my goodness, I'm not doing anything for my cancer anymore, because all of a sudden treatment has ended. So we reassure patients that the evidence shows that there shouldn't be more treatment. It could actually be more damaging to have more treatment. We review the surveillance plan with them. So they're going from, you know, every other week appointments to every 3 months appointments. So it's a change that needs to be reviewed with them. And they may have a lot of long-lasting side effects. There's a chemotherapy that causes neuropathy that patients may not have resolution of until months, even years after, or it may never go away. So these are things where we can help, you know, encourage patients to continue supportive treatment for long-lasting side effects, such as acupuncture or supplemental therapy. These patients, though they've finished therapy, you know, they've also kind of feel like they've lost a sense of social support, because they were used to going into the infusion room and talking with their friends that they've made there, as well as the staff, you know, that they've seen every couple weeks. So we want to encourage them to continue connecting with community resources and support groups. Support groups have been very valuable for some patients to feel less alone. And if they chose to hold off of work during therapy, that can also be a transition going back to work. And so we help provide support with that too. Next slide. So this next slide is about a case study. So it's an example of someone who has benefited from a lot of resources. Next slide. So actually, could you click again? Thank you. So this is a 29-year-old male, Vietnamese speaking only, who was diagnosed with stage 3 rectal cancer with attenuated polyposis syndrome. Those are big words that mean, in addition to the rectal cancer, he had many, many polyps in his colon. And because he had already developed a rectal cancer, he was at extremely high risk of developing another cancer. He was low income. He worked in an Asian market. He didn't speak English, and he had very minimal family support. His wife and his 1-year-old son lived in Vietnam, and he was here on a visa. So this was somebody that we really wanted to start treatment right away and try to eliminate some barriers. And of course, there was financial barriers. He was not able to afford these treatments on his own. So we signed him up for financial assistance, and luckily he was able to have the care free of cost. Communication was a barrier. So we made sure that there was a medical translator at all the visits, and he actually preferred a certain medical translator. And actually that is a very appropriate and recommended request to have. If there is a medical translator that the patient bonds with, that the patient trusts, and the patient can communicate well with, it's recommended that that person stay with the patient throughout all the visits if possible. He was a part of a research study, so he was involved with the research coordination of that. His consent form had to be translated in Vietnamese, and that takes time. So we were, the research team was working very hard on that to make sure that there wasn't delay to his treatment. Because he had cancer at such a young age, it was imperative that he had genetic counseling, and especially since he had a son. So hereditary testing was done to see if he had any mutations that could have been passed down to his son. Because his whole colon was full of polyps and he was very high risk, they had to remove his whole entire colon, leading him to needing a permanent ostomy, so that meant that he needed to work with the ostomy nurses to find out what he could eat and how much fluid he had to drink and how to order his supplies and how to change his bag and things like that. And as you know, as he required chemotherapy and radiation and surgery, he had an extensive cancer care team, and he didn't have a primary care provider. So we helped him establish with one. That is very fundamental to every patient going through therapy. Because of his visa limitations, he didn't have the ability to fly back and forth to see his family. So we helped with that, write a letter to the consulate to request in his specific circumstance to be able to travel to see his family. He did have post-operative complications, which were not expected. And as a result, he was discussed at the tumor board for the plan moving forward. So that's basically an example of someone who benefited from many different types of resources. So that ends my segment, and I pass this on to the lovely Marietta, who will talk more about resources we have at Providence. Thank you.
Yeah, so obviously we see it's really important to know all the different types of resources to help patients throughout the cancer journey. So speaking of resources, like Yue said, I would like to introduce Marietta Malm. She's a resource and community outreach specialist. Marietta has volunteered and worked with non-profit organizations focusing on cancer for over 10 years. As a resource specialist, she assists patients with cancer support information and resources. She works with oncology nurse navigator and oncology social worker teams to minimize barriers to care for patients throughout their cancer journey. And as a community outreach specialist, she assists in patient education and engagement events and coordinates the peer cancer support program. In her free time, she enjoys spending time with her husband and playing with her cutie fur kids, the 2 dogs, and running. Exercise not only helps reduce cancer risk, but it is key in maintaining our overall well-being. Please welcome Marietta. Next slide, please.
Thank you so much, Tuyen. So as you also saw from YY's presentation on navigating new patients, there is a lot of work and it could be very confusing. At Providence, we are a little unique. You saw all the things that our oncology nurse navigators do. They work very closely with the care team. Of course, they're all registered nurses. They can talk medical to patients. So as a resource specialist, and it's sometimes referred to as lay navigation, in no way can it ever be confused with all the work that our oncology navigators do. But of course, we at Providence want to allow the time for our oncology nurse navigators and our social workers, for that matter, to be able to focus on all those serious issues of being able to help our patients with their medical treatments and the next steps that they need to take. So oncology nurse navigators and social workers will reach out to resource specialists to help with some of those practical needs, to help with those barriers to treatment that we can help with, to allow them the time to focus more on medical needs and to focus more on psychosocial needs, the emotional needs that the social workers work with patients, because the social workers are all trained counselors to be able to work with patients for those needs. So YY mentioned a few of those resources, and if we can click on the supporting our patients button, one down. Yeah. So there are many, that should take us, if you click on that, that should take us to our website that has our, many of our resources. YY mentioned a few earlier. Is it not going to that page?
Can you click again? Otherwise, you can do the control and then
let's see.
Enter.
And control enter.
So I mentioned a few of those resources that patients need. She's determined that there is a patient that does need transportation. So instead of her having to spend the time to actually find the transportation for the patient, she will refer it to myself, and there's a couple of other resource specialists at Providence as well, so that we can actually dive in and call the patient and make those arrangements for that patient. Often it is working with 2 different clinics, because if a patient is going to have chemotherapy and then they're also going to have radiation, it's us working with both of those clinics to be 100% sure that we're not overlapping appointments and that we're able to schedule the transportation for these patients for both of those clinics. Again, financial concerns, we have amazing financial counselors that we can refer these patients to help them with billing questions and financial questions and their insurance. Sometimes, though, it may be financial in the sense of household they can't pay their rent or they can't pay their PGE bills, and financial assistance in that fashion. So again, those are given to us so that we can help those patients for resources and finding assistance. Because the one thing that is the most important is to take down those barriers so that they can focus on their medical treatment and not have these barriers to care. Again, when, speaking with the patients, we will, we may start with a request for transportation, but after speaking to them on the phone or meeting with them, we'll introduce other resources that we may have for them, which will lead to us, again, introducing them to integrative medicine team or introducing them to a nutritionist or, to the dietitians. So that is the important part of our job as a resource specialist / lay navigator, really to focus on breaking down those barriers, introducing them to educational materials and resources, and to allow the navigators and the social workers to truly focus more on the medical needs and the emotional psychosocial needs. Part of what we do as well are those support groups. So support groups that are for patients that are going through treatment, and as why I also mentioned, for patients that may have finished treatment that still want to attend support groups. I help coordinate the peer cancer support program. And actually, if we can go back one to the slides, if we can. Okay, we can do it from this one too. Yeah. Yeah, we can. It's the same. Yeah, we can do it from that one too. So the Peer Cancer Support Program is an amazing program. It is matching up peers, which are cancer survivors who have finished treatment and are a year past their treatment. So there are amazing survivors that want to give back, and they want to be connected. They want to work with patients that may be newly diagnosed, that are going through all the fears and all the questions and all the concerns, and they want to be able to speak to someone that has already gone through this. So as wonderful as our care teams are and our providers are and our nurses, our navigator social workers, it's different when it comes from the perspective of a cancer survivor. YY often refers her patients to the program, and the connections that these peers make one-on-one with the newly diagnosed patients that are trying to make these decisions is just, it's phenomenal. And I love that program that we do, and it grows. We really do try to connect as identical as possible, but all the peers just come from that place of understanding a cancer patient because they have already gone through it as well. So again, at Providence, we really do try to see the patient from many different avenues. You saw that long list of care team members that do touch a patient. And again, our navigators are the ones that try to help keep the pieces together. And we are there to assist patients with resources as much as we can. One of the things that I always tell patients is, I don't know all the answers, but please let me know if you have any concerns and I will hunt down those answers for you. So that is my presentation on resources.